Hello, my name is Dr. Denise Johnson-Miller. I am the medical director for breast surgery for the HMH Network, South and Central regions. I'm also a professor of surgery at Seton Hall Medical School. And I am very happy to present at our Komen Metastatic Breast Cancer Conference today. I'm gonna share this presentation with Dr. Bhatt. I'm going to present just a brief overview of a very complex subject, and then Dr. Bhatt will talk about treatment options for patients with metastatic breast cancer. As we know, breast cancer is the most common cancer diagnosed in women in the United States and in most Western countries. It is the second most common cause of cancer deaths for women overall, and the leading cause of death for women 45 to 55 years of age. In 2019, there are now 270,000 cases worldwide. And in 2019, there are approximately 42,000 deaths from breast cancer. Although these numbers sound awful, they are increasing primarily because of better screening and diagnosis around the world. And we are seeing the global breast cancer increase because more countries are controlling their deaths from infectious diseases. And therefore, the increased number of breast cancers are a result of women living longer in countries that normally they would die of an infectious disease at quite an early age. And now we're seeing about 23 to 25% of all cancers are breast cancers diagnosed globally. Triple receptor negative breast cancer is known with the initials TRNBC, and you'll see that through most of our presentations. It represents 15% of all breast cancers. It's especially aggressive. It can be very fast growing. Overall poorer prognosis than our more common hormone receptor positive, HER2 negative breast cancers. And it's interesting that it was first identified and studied in 2005. We really didn't routinely test for HER2 new receptor. And therefore, this entity wasn't very well known. We also started doing more genomic testing for breast cancer, and it has generated a lot of research interest. This tumor is found more commonly in patients who are BRCA mutation positive. Initially, we thought it was only the BRCA1 patient, but we also see this in the BRCA2 patient, but it is more common in the BRCA1 mutation positive patients. Triple receptor negative breast cancer are cells that have the ability to produce their own growth factors. And it allows these breast cancers that they don't depend on exogenous estrogen, progesterone, or epidermal growth factors that the common breast cancers do. And so they stop having any sensitivity to hormone. They grow and proliferate very rapidly. The tumors then become, they self-select for increased growth and proliferation, and they no longer overexpress any receptors because they form their own growth factors by turning on cell cycle entities such as tyrosine kinase. So they can make their own, I always say it's like, these are people that, these cells have their own beer. And they don't need to have anybody bring beer to the party. They make their own party themselves. We've also done some analysis at the demographics and epidemiology of triple receptor negative breast cancer. And it's quite illustrative in that it is more prevalent in younger African-American women. And 39% of all African-American breast cancers are triple receptor negative breast cancers in this young age group compared to 15% of women in the Caucasian ethnic group. And recent studies, when we look around the world, that women of African descent are represented sometimes as high as 47% with the triple negative breast cancer versus Caucasians at 22%. So when we compare other characteristics, we usually say you have an increased risk of breast cancer if you've never had children or you're nulliparous. And that's the case for the estrogen receptor positive cancers. In contrast, patients who are triple receptor negative, they have a less likely chance of having being nulliparous. So women with 2 or more children are 50% more likely to develop triple receptor negative breast cancer than women who never had children, kind of a paradox. And so it leads to questions about genetic and environmental factors, and also some implications for social disparities that affect or impact certain communities. Another paradox is because triple receptor negative breast cancers have a high proliferation rate, they also have a higher response to traditional cytotoxic chemotherapy. However, these cancers are able to form resistance to chemotherapy at a rapid rate. And so they still have lower survival, higher reoccurrence, and poorer prognosis. And research is being done at a very rapid clip to determine the biologic reasons for that. So one of the slides I want to go over to put all of our treatment thoughts into for us to better understand is looking at the treatment of triple receptor negative breast cancers with chemotherapy before surgery, which we call neoadjuvant chemotherapy. And this looks like kind of a complicated slide, but it really isn't. The two yellow and blue lines that look kind of straight at the top of this curve. So the probability of being alive is on the y-axis. The time after surgery is on the x-axis. And we can see the two top lines, yellow are the complete pathologic response in patients who are not triple receptor negative, compared to the blue line, which is a complete pathologic response to the triple receptor negative breast cancers. There's very little difference. So what that states is that if we give chemotherapy to triple receptor negative breast cancer patients before surgery, and they have a complete response in the breast and in lymph nodes, in other words, the pathologists don't see any evidence of residual cancer, the survival rate is pretty similar to patients with the more favorable hormone receptor positive HER2 negative cancers. Now the bottom two lines, the green squiggly line and the purple squiggly line, show a different picture. The green squiggly line shows patients who had residual disease in their breast after neoadjuvant therapy that were not triple receptor negative. And you can see that their survival at 7 years gets close to the 60% probability of being alive. And at 3 years, they're at about 75 or 88% chance of being alive. If we contrast that to the purple, which is residual disease after neoadjuvant therapy in triple receptor negative breast cancers, they have a 68% chance of being alive at 3 years compared to the 88% who had residual disease who did not have triple receptor negative breast cancer. So that difference is statistically significant with a p-value of 0.001. And it persists almost as being statistically significant until we get to year 6. So what's important for us in terms of follow-up, and the reason that we treat these patients so aggressively, is that if we have patients who still have residual disease after triple receptor negative breast cancer neoadjuvant therapy, we now have 2 major clinical trials that continue treatment, a different treatment using immunotherapy plus cytotoxic chemotherapy and other targeted therapies, because we know these patients have a higher rate of recurrence and a higher death rate within 3 years after surgery. Some new directions is that there's a number of immunohistochemical stains that can come up with the prognosis and kind of subdivide triple receptor negative breast cancer into certain classes that have a worse prognosis. So when we think of triple negative breast cancer, that's like a big diverse family. And within this big diverse family, there are really bad actors that are even worse than triple receptor negative breast cancer. There's metaplastic that has squamous differentiation that's really chemo resistant, very poor prognosis, but fortunately a very rare, like 1% of all triple receptor negative breast cancers. And we can do special stains to differentiate them from the traditional triple receptor negative breast cancer. I don't expect you to memorize this or to look over any of this, but when we look at cell cycle staining with the CK5s, with the c-KIT, P53 is a tumor suppressor gene, which is very much overexpressed in triple receptor negative subtypes. We can start now dividing this triple receptor negative heterogeneous group into better subgroups. We also do genomic testing on these groups using a lot of the genes that we know are overexpressed, and we can subdivide these into certain types of triple receptor negative breast cancers. The reason for doing that is then we could apply targeted treatment that may be more effective in one type of triple receptor negative breast cancer compared to another. And this very big study was a study done by us at Jersey Shore Medical Center and Riverview. It was a part of an Axelrod research project, and we found out that that there's certain stains, associations between IHC and triple receptor negative breast cancer staining. And when we look at the PK3CA staining, which is one of the mutations, really suggests that that may be an area of target. And I'm just using this as an overview to show that we are really doing a lot of in-depth study of triple receptor negative breast cancers, trying to divide this family up and to know which of the subtypes are more aggressive. Also in the subtypes, how can we attack and make them more vulnerable? Because this is not just one type of breast cancer, it's a myriad of breast cancers. So our future direction is going to be based more on tumor genomics that can target therapies attacking genes and pathways that are overexpressed, and also can start to block certain cell cycle proteins that allow these breast cancers to overproliferate. And that is going to be a key to treatment of patients who have now become more chemo-resistant after neoadjuvant and adjuvant treatment and come in with metastatic disease. What's the next line of treatment? And we already have some FDA-approved drugs, as well as novel agents that target PDL-1, P13, CD4/6 cell cycle inhibitors, as well as tyrosine kinase inhibitors. And that's where Dr. Bhatt is going to go into more detail of what the future will bring, what's current, and how we can really attack this subtype of breast cancer so we can have a more successful outcome. Thank you very much.
Hello, my name is Dr. Ruchi Bhatt. I'm a medical oncologist with Hackensack Meridian Health. I'm honored to speak today at the Susan G. Komen Metastatic Breast Cancer meeting regarding the treatment options for metastatic triple-negative breast cancer. So as we start, metastatic triple-negative breast cancer remains an incurable disease. There are unclear guidelines as to what is the best treatment of choice for these patients upon progression, and goal of treatment is to prolong survival, limit the spread of the disease while maintaining patients' quality of life, which is super important when it comes to metastatic cancer. Treatment options. So mostly chemotherapy and immunotherapy are the main treatment options. There are single drug regimens that are usually preferred for metastatic breast cancer unless patient has a very high tumor burden, means they have a lot of disease, they have visceral crisis, meaning they have disease in the lungs or liver and it's rapidly progressing. And if they have a very good performance status of 0 to 1, meaning they can tolerate the treatment really, really well. In these cases, instead of a single drug, we can sometimes use 2 drug regimens for these patients. What is the role of genetics and molecular testing in metastatic breast cancer? So genetic testing should be done to obtain a BRCA status, and a PDL-1 and MSI testing should also be performed in the tumor sample in order to decide the treatment preferences. There is next generation sequencing panels available, such as Foundation One, Biocept, etc. Those should be performed, especially when there's progression of disease on first-line treatment options. So whenever a patient has metastatic triple-negative breast cancer, there's chemotherapy given in the first line. When patients progress on these chemotherapy options, there are other tests that we should be doing, especially genetic testing for the BRCA, PDL-1, MSI, and then there are these panels that can be done that identify mutations for which there is targeted treatments for the metastatic triple-negative breast cancer. So what are our preferred regimens for the treatment? So anthracyclines such as doxorubicin or liposomal doxorubicin, which has not been, if that has not been given before, can be used. We can use taxanes such as paclitaxel, docetaxel, albumin-bound paclitaxel. These are all our taxanes that can be used in these patients. There are antimetabolites such as gemcitabine and capecitabine that can be used. There's microtubule inhibitors such as vinorelbine, eribulin, and there is data that there is improved overall survival with the eribulin. So those can be used. And then there's cyclophosphamide, irinotecan, those can be used as a single agent or a combination of some of the regimens, as I discussed in the next slide, can also be used. So for the combination regimens, we can use anthracycline plus cyclophosphamide or epirubicin plus cyclophosphamide. There's a regimen called CMF, which is cyclophosphamide, methotrexate, and 5-FU that can be used. We can use docetaxel and capecitabine, gemcitabine paclitaxel, carboplatin paclitaxel, and paclitaxel bevacizumab. So these are some of the combination regimens that can be used in treatment of metastatic triple-negative breast cancer. So usually the route of administration is IV. So NCCN guidelines to this year are unclear as to what drugs we can use in the first-line setting, but there are preferred regimens that are highlighted as in the previous slides. Most of the chemo is given IV, as you all know, for metastatic breast cancer. There is one treatment that is called Xeloda or capecitabine that is an oral medication that can be given. The side effect profile from all the chemotherapy regimens differs based on the class of medication, but most commonly, a lot of patients have myelosuppression, there is GI and hepatic toxicity, and there could be fatigue related to most of these IV medications. So patients have to be really in a good performance status in order to tolerate these IV medications, which most women are when they're diagnosed. So most women end up getting these IV treatments in the first line setting. Now we're going to move on to some targeted therapy. And this is usually used as a second line option once a patient with metastatic triple-negative breast cancer has gotten in the first-line IV chemotherapy, and then they have progression of disease, meaning their cancer is growing on that first-line regimen. Then we want to do something in the second line, and for that we are trying to use more and more targeted treatments. So BRCA mutation is found in about 1 of 400 people. There's olaparib and talazoparib. Those are the 2 US FDA-approved drugs for metastatic breast cancer. If the patient is found to have a germline BRCA mutation or a suspected deleterious germline BRCA mutation, and they have to be HER2 negative, and they have to have treatment. They should have had treatment with chemotherapy in the neoadjuvant, adjuvant, or metastatic setting. We can also consider the uses of these PARP inhibitors with purely somatic alterations in BRCA1 and 2. There is emerging high platinum sensitivity in BRCA patients, but randomized controlled trial data is lacking. So if you are BRCA mutated, then we tend to use more carboplatin or cisplatin in this setting because there is data that the cancer is more sensitive to the platinum agents. So dosing and administration for olaparib, it is an oral drug, 300 milligrams twice a day until disease progression or unacceptable toxicity. Talazoparib is also given orally 1 milligram once daily until disease progression or unacceptable toxicity. These are PARP inhibitors, and the major side effects are GI side effects such as nausea and vomiting, but we have medications for that are available, and patients are usually told to take that medication just preemptively to prevent nausea and vomiting. You can get some immunosuppression, myelosuppression, pancytopenia, and there's about 1 to 2% chance of getting MDS or AML, which are blood cancers. we also check for PDL-1 expression in these metastatic triple negative patients. So if the PDL expression is more than or equal to 1%, immunotherapy called atezolizumab plus albumin-bound paclitaxel, which is a chemotherapy. So the combination of chemo and immunotherapy is approved in patients with triple negative breast cancer that cannot be treated surgically, or the tumors are positive, and the tumor has to be positive for PDL-1, and the expression has to be more than or equal to 1%. The approval for this regimen with atezolizumab plus Abraxane or albumin-bound paclitaxel is from Impassion 130 trial, which is showing improvement in progression-free survival with the combination regimen. There is recent upcoming data from a follow-up study called Impassion 131. It does have the approval in jeopardy, but we still are, for now, are treating patients with triple negative metastatic breast cancer who cannot be surgically removed. And if they have PDL-1 expression, they can be given this atezolizumab plus albumin-bound paclitaxel. It's a combination of chemoimmunotherapy, and it's well tolerated in most women. So atezolizumab is an IV medication. It's given 840 milligrams IV on days 1 and 15 of every 28 days in combination with nab-paclitaxel or Abraxane, which is 100 milligram per meter square on day 1, 8, and 15 of a 28-day cycle. So atezolizumab, as I mentioned earlier, is an immunotherapy. It's an anti-PDL-1 antibody, and nab-paclitaxel is a microtubule stabilizer and inhibits cell replication. The major side effects from this regimen are activation of autoimmune condition, itis, or inflammation of any major organ system. That is from the immunotherapy. So the patients could have a hypophysitis, which is a swelling of the brain, or pneumonitis, which is swelling in the lungs or inflammation in the lungs. They could have kidney inflammation. They could have liver inflammation. So these are the major side effects from the immunotherapy. And there's some neuropathy and myelosuppression with the chemotherapy component of this regimen. Next, if the patient has a TRK fusion, so these are activating fusions that involve the NTRK gene, can be identified in a variety of adult and pediatric solid tumors. These are identified by using the NGS sequencing panel or a fluorescent in situ hybridization. So like I was mentioning earlier, when patient has progression on first-line treatment, we send an NGS panel like Biocept or Foundation 1, and these are able to identify the mutations such as NTRK. So there are two medications called entrectinib and larotrectinib. Those are oral inhibitors or TRK proteins, and they're both approved for solid tumors with the NTRK fusions. So regardless of where the tumor came from, whether it be breast or lung or kidney, if the patient has the TRK fusion, patient can get this entrectinib and larotrectinib, these two oral medications. So it is considered tumor agnostic approval, meaning it's for tumors with a specific genetic feature rather than a certain type of tumor. So how are these medications dosed? Entrectinib is given orally 600 milligrams once daily until disease progression or unacceptable toxicity. And larotrectinib is also given orally 100 milligrams twice daily until disease progression or unacceptable toxicity. The mechanism of action, it inhibits the tropomyosin receptor tyrosine kinase or TRK. The major side effects are edema, cytopenias, visual disturbances, GI side effects, fatigue, neurotoxicity, and hepatotoxicity. But if you have this or the mutation, you can get this oral medication. So these are some of the options that we think about in the second line. What if the tumor is MSI high or deficient in MMR or has tumor mutation burden, which is high? So again, these tests are done on the tumor sample. So these mutations are rare in breast cancer, about less than 5%. Pembrolizumab, which is an immunotherapy targeting PD-1, is approved for treating solid tumors with high MSI, which is microsatellite instability, or deficiencies in DNA mismatch repair, or for solid tumors that have a tumor mutational burden of 10 or more mutations per megabase of DNA. Data is lacking in breast cancer regarding these mutations, but it's still an approved medication. So if the breast cancer is found to be one of these three, MSI high, deficient MMR, or tumor mutation burden high, we can consider pembrolizumab in this setting for these patients, which is an immunotherapy. So it's given 200 milligrams every 3 weeks or 400 milligrams every 6 weeks. It's given in an IV form, and it's continued until disease progression or unacceptable toxicity. The mechanism of action is a selective anti-PD-1 humanized monoclonal antibody. And again, the major side effects are itis or inflammation of any organ system, like we discussed earlier, most commonly being pneumonitis and colitis, which is inflammation in the lungs or colon. So those are our main side effects when giving immunotherapy. Also, one thing to be really aware of when giving immunotherapy is a patient has any underlying autoimmune condition, such as lupus or rheumatoid arthritis or Sjogren's. If patients have any of these conditions, we just have to be really wary about giving chemotherapy because it can cause a flare-up of your autoimmune condition. So what do we do when a disease is heavily pretreated, meaning a patient has metastatic triple-negative breast cancer and has gotten 1 or 2 or 3 chemotherapy agents in the past? What do we do after that? So for a heavily pretreated disease, there is a new medication called cetuximab govitecan HZIY or Trodelvy. It's an antibody drug conjugate which has been recently FDA approved in April of 2020 for patients with metastatic triple-negative breast cancer who have received at least 2 prior lines of treatment. And efficacy was demonstrated in IMMU 13201, which was a trial. It improved overall response rate and the median response duration in patients with metastatic triple-negative breast cancer when they were treated with this medication. So how is cetuximab govitecan given? So it's given IV, it's given 10 milligram per kilogram on days 1 and 8 of a 21-day treatment cycle. It's an antibody drug conjugate, and the major side effects are neutropenia and diarrhea. It is a fairly new medication, so not a lot of people have gotten it yet. So there's more to come regarding the tolerance and toxicity profile, but from the trials, it looks like it caused mainly neutropenia and diarrhea in the patients. New treatments on the horizon. So we've talked about the treatments that we talked about so far are the FDA approved treatments that have been given for the IV chemotherapy has been given for years. The new oral medications and the targeted medications and the immunotherapy that we talked about those are all recent approvals in the last 3 to 4 years. There's more treatments on the horizon. There are drugs that are targeting mutations such as ATK1 or RET or CMET. They are in the pipelines and trials, and these we are awaiting approvals and more trial results in order to give these drugs for women with metastatic triple-negative breast cancer. There's more to follow on the clinical implications of these medications and their use in the clinic and the office setting. So we don't have solid data yet, but there's drugs, the RET and the CMET especially, we have drugs that are targeting those agents. They are approved in other cancer settings, such as lung cancer has both the approvals. So we're awaiting the trial results regarding these medications in the metastatic triple-negative breast cancer or just breast cancer setting to use these drugs in women who have metastatic triple-negative breast cancer. So in conclusion, metastatic triple-negative breast cancer remains a disease with poor prognosis. It's a challenge to treat. We should always involve palliative care early on so that patients can get the support that they need. If the patient has gotten 3 or more lines of treatment and they have a declining performance status of greater than or equal to 3, meaning they're spending a lot of time in their bed, or if they're not able to do their activities of daily living, then palliative and comfort measures should be considered. And clinical trials are definitely encouraged for appropriate patients. This is how we get new drug approvals. This is how we can test the drugs on patients. And a lot of patients have really good results with clinical trials. So if there is something available, patients should definitely sign up for clinical trials. And thank you very much for listening, and I'm available for questions.